Good evening, everyone. Thank you for joining the 17th ACNN webinar. Our speakers today will be Professor Dr. Nelsie from Brazil and Mr. Samuel from Tanzania. He's a clinical nurse. And Professor Dr. Nelsie is a pediatric surgeon at Federal University of Sao Paulo, Brazil. And Professor Dr. Nelsie also a secretary for ISBN, Neurosurgeon Coordinator Global Initiative for Children's Surgery, full member of ACNN 𝒾𝒆𝒃𝒊𝒂𝒓, Sao Paulo, strengthening parent support coordinator, Scientific Department of Neuro Society of Pediatrics, Sao Paulo, and President of ABMN. And Dr. Nelsie also is a Vice President of Latin American International Medical Women Association. And today she will talk to us on spina bifida or catarrh. And our session chairs for today will be Professor Patricia Dastori. And Professor Patricia is an associate professor in the Department of Neurosurgery, Federal University of Sao Paulo, Brazil. Sister Sylvia from Tanzania will be the session chair for the nursing session. She's a clinical nurse, a practitioner, and clinical mentor of the neurosurgery department in Tanzania. And our moderators will be Professor Nobuhito Morita, and he's the director of Division of Pediatric Neurosurgery, Kitasato University School of Medicine in Japan. And Dr. Nadia is the neurosurgeon of Department of Neurosurgery, Hospital Kuala Lumpur, and Hospital Tunku Azizah in Malaysia. So without further ado, may I call upon Professor Yoko Kato to give us a short opening remarks. Prof, you are muted, Prof.
So thank you very much, Matrini. Always, you organize such a wonderful webinar. So today we focus on the spina bifida. And from Japan, Morita Sensei is one of the best pediatric neurosurgeon who is the specialist on this field, I think. So we're looking forward great to lectures. Especially the Nelsie is one of the best friend of mine. So all the best. Thank you very much.
May I call upon Professor Patricia to introduce Professor Dr. Nelsie?
Oh. Yes, thank you. Please, Dr. Nelsie, you are presented. So I think that you can begin your presentation.
Good morning, good evening, good afternoon. I think you are seeing my screen. I was already introduced. It's really a great honor to be here. And thank you very much, Professor Yoko Kato. You are our inspiration on the last decades, and you still on top for every woman neurosurgeon around the world. Really is a privilege to be your friend and to be online with all of you. I'm living in São Paulo. It's one of the 10 most populous cities in the world. And about spina bifida occulta, I choose some topics because each topic we can spend a lot of time on it, but mainly about classification, diagnosis, and some case basis for discussion to be more interesting for the audience. My friend 𝒂𝒏𝒂𝒓, that's unfortunately passed away last year. He thought never trust embryologists because the results are based on mouse, on Drosophila, on other animals and pigs, and we need to trust the results. But to talk about some embryology, just to remind us, a short video for the normal embryology.
Dividing. By about 4 days after fertilization, a solid ball of cells called a morula forms. The cells continue to multiply, and by day 5, the cells separate into 2 groups, the inner cell mass, which will become the embryo, and an encompassing sac called the trophoblast, which will develop into the placenta. Trophoblast cells secrete fluid, creating a cavity, the blastocele, with the inner cell mass at one end. At this stage, the mammalian embryo is called a blastocyst. The cells of the inner cell mass eventually form 2 layers, the epiblast and the hypoblast. The epiblast is thought to contain the cells that will generate the actual embryo. Critical to the early development of all vertebrate embryos is the process of gastrulation, which occurs between days 13 and 19. Gastrulation results from the movement of cells toward the midline and then forward along the midline, forming a groove called the primitive streak. The end result is the production of the 3 primitive cell layers, the endoderm, the mesoderm, and the ectoderm. The nervous system develops from the outer layer, called the ectoderm. As this cell layer thickens, it becomes a distinct epithelium called the neural plate. Uneven rates of cell division form a groove called the neural groove that will become the midline of the embryo. Ridges of ectoderm continue to bulge on both sides of the midline. The tops of the neural ridges eventually come together, forming the neural tube. The interior of the neural tube becomes the...
It's just the normal embryology, and from here, if we can have some disturb on this phase, we can have some troubles on the skin, on the central nervous system, on the spinal. If is on the 3rd week of fertilization, on gastrulation, or on the after 4-7 weeks on the secondary neurulation, we have less complicated malformation. On basis, more early we have the malformation is more complicated. We have more tardive manifestation, we have less complex. For example, on secondary neurulation, we can have lipomas, even on this disjunction premature a little bit earlier. And on gastrulation, we have split cord malformation and neuroenteric cyst. An overview about the neural tube defects. We have more or less 1 or 2 cases for 1,000 births, and the risk factor have a relation with non-genetic maternal nutritional status, pregnancy diabetes, early pregnancy exposure to anti-epileptic drugs, and previous pregnancy affected neural tube defect. On classification, there is many ways to classify this dysraphism, but the main separation is spina bifida occulta or spina bifida aperta, anencephaly, encephalocele, or anencephaly. On spina bifida prevention, we can go to folic acid fortification. The recommendation is 200 micrograms a day for folic acid, reducing almost 70% of the cases. is vitamin B9, but this is only possible for open neural tube defects. For spina bifida occulta, there is no rule for prevention. Around the world, 60 countries have the implementation in mandatory fortification staple foods. Brazil is on this list and is mandatory the fortification since more than 20 years from them. And we published recently the spina bifida fortification 20 years before and 20 years after stapless food fortification. And for our records, spina bifida patients still increase. We need to try to go deeper inside and try to see what still increase this spina bifida case besides the fortification food. The separation open spina bifida and spina bifida occulta is very important to recognize after birth. Why? Because open spina bifida, we don't have skin closure. It became an urgent neurosurgical procedure. For spina bifida occulta, we have normal skin, we have time to do some exams, ultrasound, X-ray, MRI, CT scan, and we can plan this surgery with more time and no rush. We need to take care for the family, do orientation, but it's not urgent case that we need to move for a tertiary hospital right in the moment when the child born. The spina bifida occulta can occur in the skull or in the brain, encephalocele, the cervical, and most of them is on the lumbosacral, like we can see on these pictures. And reinforcing the idea is not urgent surgery. We need to look at the diagnosis to do the difference and to take care with all the equipments we need. This spina bifida occulta, there is a lot of names, pathology, classification, but today we will stay in 2 or 3 main pathology: lipomas, split cord malformation, and dermal sinus. Because they have some skin signs to orientate us about the diagnosis. What kind of cutaneous signs we can see? Dimple is not necessarily all the cases related to communication with the spinal cord, with dermal sinus, but at least ultrasound can be a screening for this patient to try to see what of them need to have a look more closely than the normal skin. And what about the clinical manifestation to be aware for this patient with spina bifida occulta? Usually related to genitourinary dysfunction, recurrent urinary tract infection, chronic constipation, foot deformity like we see here. The right feet is different from the left. Legs deformity, asymmetry, frequent falls, skin lesions, not healing skin lesion, mainly on the lower limbs and usually on the feet. And we need to have at least the diagnosis. We can start with regular X-ray, but it's not simple to find these diagnoses. Like we see here, the L5 open spina bifida, bone, open bone, not necessarily the skin. And the ultrasound can help, but X-ray, CT scan, and MRI are not mandatory, but at least necessary to be sure what kind of malformation we are dealing. Like this CT scan with 3D reconstruction, all the sacrum is open and we have a bone inside the middle. The MRI is the gold standard for knowing where is the spinal cord, where is the malformation. If we have the malformation connected to the skin or inside only the spinal cord. On this first case, we have phylum terminalis lipoma, we have dorsal lipoma, and we have skin with lipoma, subcutaneous lipoma, that help the diagnosis. There is several classifications only in lipoma. We use more the classification from Pang. And more recently, the antenatal diagnosis can do the spina occulta or spina bifida occulta diagnosis. But even with MRI, sometimes it's difficult to be sure 100% that we have skin covering the spinal defect. When we was dealing with myelomeniingocele fetal surgery, in 2 cases, it was almost impossible to determine that these were skin protecting the malformation or it was a real myelomeniingocele. And one of the cases we opened and it was myelocystocele with all the skin covering the defect. It's not a good case for fetal surgery. If we are talking about spina bifida, we need to know the normal and the pathological level of the conus. Normally, we have above 1 year in T12-L1. If it's below 1 year of age, we can accept L1, L2 level, the medullary conus, and above only the cauda equina. On MRI, it's easy to see if we have a sagittal T2 slice. We can see in the right side the medullary conus arriving in L5-S1, and on the left side we have the normal conus on 5, back, 5, 4, 3, 2, 1. L1 level, it's normal positional. And here L5-S1, it's pathological level, even if we don't see lipoma or other malformation, we have tetrahedrocords. Is a good topic for the discussion. And the management, what we do with spina bifida occulta, symptomatic or asymptomatic, correlation symptoms with image, multidisciplinary team evaluation. The idea is to have urologist or nephrologist, gastro or coloproctologist, orthopedic team, and rehabilitation team working together. And the gold standard that we don't have at the moment, even after some decades, is to have all these professionals in the same day. These families spend their life going from one doctor to another doctor to the rehabilitation team, and we can't put all these professionals together. Even if we know since 30 years ago, it was already the reality in high-income countries. One example, these patients, 80 years old, progressive bilateral lower limb pain when it was walking, bladder and bowel control since 2 years. He was football player with his father and perceived that he was tired before normally. The X-ray shows the scoliosis and the MRI showed this huge lipoma, complex lipoma. even if you don't have related symptoms with the tract-urinary system, the exam shows left dilated renal collected system and scar on the kidney. Is very, very important to have these close eyes to the functional, the renal functional, to avoid renal transplantation or chronic renal failure. And he was sent to surgery with motor evoked potential and some sensory evoked potential. The first 10 years on my life, I operate these lipomas without any monitoring because wasn't available. But fortunately now the monitoring is available. And this is the MRI 5 days post-operative. The spinal cord is still lower in the level, but the improvement came without pain in 3 days. And is a short video. Let's see if it's running. It's not a video. Is this particular case, we choose transverse incision, but we can use also midline incision. Is just a professional, a surgeon choice. This we decide to do transverse incision because it was huge mass, and I think it was facilitated the access. We learned that on lipomas, we need to go around, try to avoid to go in the midline. The video is not 100% perfect, but we can see how we can start from the normal tissue to reach the pathology. And when we are with a normal tissue, it's better to try to find laterally where we have the level of the lipoma and try to separate the lipoma from the roots. It's not all the surgery, but a piece of surgery. We need to resect more lipoma to have at least a visual field inside the spinal canal. And piece by piece, we can go. There is some colleagues that use ultrasound aspirator. Maybe Dr. Patrizia D'Astoli can give his advice about using ultrasound aspirator in the lipoma surgery. And the other case is less complicated, is just a phylum terminalis lipoma. Is easy to operate compared to a complex lipoma, but if they have symptoms, is mandatory. And there is some advice, even if the patient is asymptomatic, we can perform a prophylactic surgery, but we can discuss together during is the small. Here we can see this surgery. It's maybe 1 minute video. The start is like the lipoma. We try to find the dura mater, the normal dura mater. We open under microscope. Some colleagues do with loop, but we feel more comfortable on this stage of the surgery to use microscope. I think it's more safe for the patient. And usually the phylum terminalis with lipoma is quite easy to see. We can discuss if it's mandatory to have neuromonitoring intraop or if we can perform this surgery without monitoring. We just open the dura and fix laterally before to find the phylum terminalis. some arachnoids to see better where is the roots and where is the lipoma. We saw in the middle the lipoma, and we tried to separate from the rootlets with a cotton just to protect before cutting. The families in the postoperative tell us still have phylum terminalis lipoma there because we doesn't cut off all this lipoma. We just be sure that there is no rootlets inside, and we can cut, send to the pathology, but we just cut a little piece to separate the cranial to the caudal level. We just fix with a stitch to have this piece, this small piece in our hands. And you can see the cranial just flying inside quickly, and the patient is relieved, and we send a small piece to the pathology. I recommend to you to see this paper, the classification and indication for lipoma. The case 3 is sinus, dermal sinus, spina bifida. The recommendation is prophylactic surgery if we don't have clinical related. The split cord malformation, type 1 and type 2. The type 1 is with bone separate to spinal cord, and the type 2 is two spinal cord inside the same canal. Is another case with diastematomyelia or split cord malformation with type 1 with bone spur on the center, and this hair in the back is pathognomonic, but it's not mandatory, the presence, but if it's there, we need to look at and not to just relieve the skin from the hair. Yeah, we need to do investigation. Some more rare syndrome, when we have vertebral, anus, trachea, esophagus, and renal malformations, Vacter or Vacterel syndrome is fortunately exceptional to have. Some difference in open and occult spina bifida. The open is more common in boys, and the occult more common in girls. And usually open myelomeningocele or open spina bifida, we have brain with Chiari-2 malformation and hydrocephalus, and on lipomas or occult spina bifida is exceptional to have brain malformation associated. With Patricia, we present this paper that our medical student Victoria wrote. After more than 200 spina bifida surgery, open and occulta spina bifida, 30% of this patient, it was necessary to reoperate, and the clinical symptoms, it was orthopedical deformity, neurological deficit, urological dysfunction, and intestinal dysfunction. But the symptoms that was more than 100% improvement, it was low back pain on these patients when they was operated early in age, and the mean age they was operated now, it was above 5 years. The take-home message, split cord malformation, dermal sinus, we can indicate prophylactic surgery. The indication for lipomas, maybe the phylum terminalis and dorsal lipomas, we can do prophylactic without any problem, but the chaotic lipoma or lipomyelomeningocele, maybe it's better to have some symptoms because it's more complicated and difficult to relieve 100% the lipoma for these patients. Is lifetime commitment and multidisciplinary team. We never are alone when we are taking care for others, and have a mentor that we can have some inspiration in life, I think is the best we can find to continue to help others. And thank you very much for this indication and invitation. It's a privilege to be with all of you. Thank you very much.
Thank you, Prof. Dr. Nancy. It's a very informative lecture. May I call upon Prof. The commentators, Prof. Morota and Dr. Nadia, to give discuss on this, or any comments or suggestions.
Thank you, Professor Nelsie. It's good to see you after a few years. Hope you're doing great. The lecture was very, very good. It is something striking and also very meaningful that we actually recognize this problem early, and it is actually referred to the neurosurgeons early as well. And having a multidisciplinary approach for spina bifida, both abrata and occulta, is very important. I would just like to ask you, in your practice, especially for cases of tethered cord, those dorsal lipomas and the phylum terminale, how early, in asymptomatic patients, how early do you operate them? And in your series of cases, do you see a trend in outcomes in cases that you operate early versus those that you operate slightly later in age?
Thank you, Nadia. Yes, to see you online a few years after, then we was together in Kuala Lumpur is great too. Your question about the clinical, the spina bifida patient is very difficult for the families. For us, we see the patient and the indication, we try to talk each other, even though we don't have all the spina bifida clinic together. They send to us, the orthopedic surgeon sent to us, the urologist, that there is some worsening signs. Usually the pain is the most important, but we perceive that we can relieve most of the patient symptoms more than 50%, not related with the age of the patient. It was 5 years to 15 years. It was, maybe we don't have numbers enough to perceive this difference. More than 200 patients, but reoperate was only 20. We have 10 other patients in a waiting list to be operating or reoperating, even for lipomas or myelomeningocele patients. And about the best age to operate, I think 6 months old can be a good cutoff, or below 1 year of age, at least phylum terminalis, dermal sinus. But most of our colleagues agree that 6 months old is a good period. It's not necessary and not indicate to operate with newborn, few days of life, to operate this kind of surgery. I think we don't need to do it. We have time to do at least ultrasound, some investigation, and to be sure that we have time. Only one case, it was 8 months old. I was waiting until 12 because the family was living far away. and the child just stopped moving the right leg. And we decided to do urgent surgery for the deficit. But it was only one case on these 3 decades. I don't know if I answer your question, Nadia.
Okay,
Yeah.
let me comment something. Professor Jaron, thank you very much for your lecture. And, the spinal lipoma has several types. And some types have the very symptomatic, even in the newborn time. And what I'd like to say is that the spinal lipoma grows rapidly at the first 3 months of the age. And so in my when I decide to operate or not to operate or wait or something, of course, the symptomatic patient, you have to operate earlier. This is a very basic concept. But even in a symptomatic patient with a huge spinal lipoma, sometimes I decide to operate before the patient was born and the diagnosis soon, and before he reaches the age of 3 months, I operate because the spinal lipoma grows rapidly and most likely to compress the neural element during the growth. So that somehow we need to combine both the symptomatic or asymptomatic and the size of the spinal lipoma and the time when it was diagnosed. It's also very important. That's what I'm thinking. Yeah.
Thank you very much for your comments and advice, Dr. Morata. We respect a lot. And I leave 2 moments about surgical resection for these tumors. I was more related to 𝑚𝒆𝒍𝒏 that it was partial resection for the lipomas. But with the time goes by, and Dr. Pang showed us that we have more better outcome if we relieve all the lipoma from the spinal cord. I would like to listen from you. Did you try to do total resection for this lipoma even at 3 months of age, or did you do debulking like it was in the past with Dr. Zera teach us at that time?
Okay, that's a good question. I classify the spinal lipoma from type 1 to type 4. The type 1 is what we call the dorsal type, and it develops during the first, the primary neurulation. Type 2 involves that, what to say, between including both first and secondary neurulation. And type 3 is a spinal lipoma develops from the secondary neurulation, early phase. And the type 4 is the late phase. And usually the type 4 is a filum lipoma. And type 2 and type 3, the radical resection is impossible from the beginning because the border between the spinal lipoma and the neural tissue is somehow mixed. So there is no clear phase for dissection. You can do the total resection, semi-radical resection only for type 1. This is the first issue. So if I diagnose the spinal lipoma type 1, I try to remove as much as possible radical or semi-radical resection. But if that spinal lipoma is diagnosed type 2 or type 3, I do only partial resection as traditional, 70% or something, around 70 to 80% of the resection. So that radical resection or not radical resection, partial resection, depending on the type of the spinal lipoma. Yeah.
Thank you very much.
Sister
I agree
Sylvia,
with you.
Sister Sylvia, you have something?
Yes. Thank you, Dr.
Please.
Professor Nelsie, for such wonderful information. I have come across with a little boy who had both hydrocephalus and spina bifida occult, and it was closed at the age of 3 months, but they were treating the hydrocephalus. And during the care of this patient, she developed some sort of stridors and difficulty in breathing, where he requires the intubation and ventilator support several times. So I read somewhere that those patients with spinal bifida, they have the latex rubber allergy. Any comment on that? Thank you.
Yes, thank you for your question, Professor Sylvia. If we have respiratory troubles, we are talking about probably open spina bifida with myelomeningocele and Chiari malformation. Is the most common cause of death on the first 2 years of life for these patients. And hydrocephalus can try to relieve these symptoms. If the hydrocephalus is well treated, we have the second line of treatment that is posterior fossa decompression. And yes, latex allergy is an issue for this patient. After 3 surgical procedures, they have more than 70% probability to develop latex allergy. And is a good practice. I doesn't talk on my lecture. Start from the beginning. For this patient, open spina bifida, we try to introduce, even in fetal surgery now, the latex-free protocol. I know is more expensive than normal surgical environment, but we save lives delaying this manifestation with a latex allergy on spina bifida patients. I don't know if it's okay, the answer, Professor
Okay,
Sylvia.
you. I'm Sister Sylvia. Sorry, I'm not professor. I'm a nurse, Sister Sylvia.
Okay, sister. Probably you are teaching your colleagues.
Yes, but I'm not yet in the position of professor. Thank you.
Welcome.
There any more comments or any other questions?
I have a technical question to ask Professor Nelsie. For patients, younger patients under the age of 1, is there any technique that you use intraoperatively to reduce CSF leak, seeing to the fact that their dura is like thinner and whatnot? Yeah, because we see that a lot in our practice and we try to reduce it, but that we see a lesser rate of CSF leak in older children. More than 2 years old, usually.
It's a very good question and very hard decision. What do we do during surgery to prevent CSF fistula? We have these complications too. We try to do a dramatic plastic repair when we don't have enough tissue. But I can tell you, even though when we do 100% microscopically suture, can happen. And once it was, when the tissue, it was doing the stitches, the tissue that was receiving what wasn't enough healthy to support the suture. I think the key is try to find a way to have healthy tissue to close and try to enlarge the spinal cord canal to have more space and try to avoid this 13-15% retethering that we have. Mainly in lipomas. If we don't do duroplasty, probably we will need to reoperate again in 5 or 10 years. These patients is exceptional, but we have patients that it was necessary to redo twice this operation for retethering on spina bifida patient. But we don't have this answer and this solution, dear. We try to put glue if is available. Is not all the time available in public hospitals, but after the stitches, we put glue. And if you have dura mater replacement, we can put above, try to avoid, but it's not 100%, dear.
May I comment something?
Sure, Professor Morata, a privilege to have you.
Okay.
We learn from you.
Yeah.
Yeah. The closure of the dural defect, I usually use the fascia of the muscle fascia away from the midline. You know, in the large lipoma, the fascia is also lacking. And the most important issue, in my understanding of my operation, is that, okay, I use a fascia, I harvest a fascia away from the midline and do the dural. But more important is a watertight closure of the fascia. So sometimes I flip the fascia, dissect the surface, dissect the fascia from the muscle and flip, and then close watertightly. The dural closure, watertight dural closure is of course important, but I don't believe it's perfect. The more important is the closure of the fascia layer watertightly. This is more important. Another issue is okay, after you close the fascia, you close the skin. But between the skin and the fascia, there is dead space. So I try to hook up the skin, subcutaneous skin tissue to the fascia so that you can kill the dead space under the skin.
Thank you, Dr. Morata. Just a clarification. If I understand well, you do the duroplasty first, watertight, and you close the fascia. You don't use fascia lata, for example, to do a duroplasty. Okay?
No,
Just to be sure that you understand.
I use the fascia only on the side of the surgical site. So I undermine the skin and flip the fascia while it is still connected to the original fascia. I don't leave the fascia away completely. Always it's a vascularized fascia. You flip and close. Okay?
Okay, thank you very much. Just to be sure. Thank you.
Yeah.
Okay, Prof. Gato, any comments, Prof. Gato?
Thank you very much, Nelsie. It was a great lecture, as always. So I think it's one of the most important the issue. You included everything. So it's very clear. Thank you so much. Great lecture.
Thank you very much.
So, congratulations, as always.
Thank you, dear.
May I call upon Prof. Patricia to do the closing remarks for this session? Prof. Patricia?
Yes, I'm here in a moment.
Okay.
Thank you. Thank you. Oh, thank you everyone for the wonderful discussion. Congratulations, Nelsie, and all the participants for this discussion about this very important and controversial subject, the lipomas in the children. So thank you. I think that we can go to the next class. Thank you.
Thank you, Prof. Patricia. Now, may I call upon Sister Sylvia to chair the second session? Sister Sylvia?
Thank you for granting me such an opportunity once again. I'll call upon Mr. Shem Chuma, a registered nurse and clinical practitioner from Muhimbili Orthopedic Institute, to share the nursing perspective on the spinal bifida occult. We have heard about how is it about, so that he's gonna take us through nursing perspective. Welcome, Mr. Chuma. Can you?
as a presenter as been introduced by Sister Silva, that I'm a clinical nurse from 𝑚𝒂𝒏𝒂𝒓 Orthopedic Institute, Dar es Salaam, Tanzania. I would like to pass it through a little bit concerning the topic of interest. Unlucky enough, I have a technical problem presenting my slide. I think the team can help me on that to post that on the screen, please. My turn again.
Trying to share your presentations, hold on.
Okay.
Can you see?
Okay. Yeah, thank you. Okay. My introduction. Go to the next slide, please. Yeah, spinal bifida occurs is a neurological tube defect as characterized by incomplete closure of the vertebral arch, usually without a visible protrusion of the spinal cord meninges. As has been introduced by, being said previous by the previous speaker, Professor Narsi. A lot have been spoken about it, but I pass you a little bit on concerning nesting perspectives. And while they're often asymptomatic, some individuals may experience neurological and the musculoskeletal and the urological complications as the condition evolves. Nursing management play a crucial role in early detection, monitoring, and educating the patient families regarding the condition. That is the pictorial presentation of the types of spinal bifida. Basically, we're doing the first one is that spinal bifida occult. Slide, please. Concerning nursing management, this patient with spinal bifida occult, as a nurse, the big role is to make sure that you make a thorough assessment of these patients and the diagnosis. Physical examination is concerned with external signs such as limping or hair tufts or lipomas and over the lower spine. These are the things that you have to observe first. So before going to the radiological examination or other tests, these are the key elements that can lead you to know that this patient for this condition. Also, neurological assessment is very vital. As we know, as the disease progresses, these patients may progress some weakness, so that you have to be aware and completely on assessing the weakness and assessing the deficiency and all the reflexes that's supposed to be there to the normal person. Also, musculoskeletal evaluation is very important. The screen concerning scoliosis, the length of the legs, the discrepancies and the deformities. Also, you have to assess the gait and posture of this patient concerning musculoskeletal function. By assessing all of this, then it can give a clue to notice the early signs and symptoms of this condition to such patients. Also, urological screening, you have to monitor the signs of urogenic bladder dysfunction. Because failing to do this, you can lead to other complications, like if the patient develops this neurogenic bladder dysfunction, you might end up with urinary incontinence and that may lead you to develop some pressure sores if you're waiting always, and if not intervention will not be taken earlier, then it can develop to some complication like burning bed sores. Also, diagnostic tests, as been said by the previous presenter, X-ray, MRI, and ultrasounds. There are the tests that are diagnostic tests that have been made or done so that we identify this condition. As it was said, MRI is the gold standard for noticing the problem. At 2, for nursing care, as we know, nurses, they always stay with these patients and the families always for a long time. So the major role is to make sure that these patients, they are aware of the condition of their loved ones, if they're their babies. So condition awareness, you have to educate the patient concerning the abnormalities that has been appeared. Instead, if the disease is not yet treated, so you have to educate the patient or relatives concerning the diagnosis, so they may be aware. It's just it's a defect that happened during growth. It's happened to some of the people. They should not take it as the major problem that they can complicate their life situation or their daily living activities, because some they may develop some stress concerning the condition. So you have to give them awareness so that they can know that if it's treatable, so they can comply with the condition. Also, signs of progress. In early detection, then if you educate them the signs of the symptoms of the condition, if they be aware of it, so even if it's happened, they will be aware of, and they will take some action earlier so that they may come to health facilities to get help and maybe treatment in early stage, rather than, because most of the relatives, the parents, they delay to come to bring the children to these facilities for treatment. Also, preventable measures, if they are in the world, preventable measures that should be addressed to them so that they can prevent the recurrence or progression of the condition. So if the condition is not treatable by surgical aspects, then proper posture, proper body mechanism, and core strengthening exercise that are used to prevent the spine from damaging the neurological aspect. It will help them to care their loved one at home, and also while they are still observing them. As we know, the disease progress, some of the patients, they may develop some pain syndrome to the area, or some they may like get to the legs. So pain assessment should be a mandatory thing to be taken to the patient, because as the patient develops these things, it's devastating a little bit. So pain assessment should be done thoroughly, and some medication to relieve that pain that's supposed to be given on time, so that this patient may stay comfortable with no any discomfort. Also, physical therapy. This is one of the major therapy to relieve some pain and strengthen the muscles. So physical therapists, they're supposed to be there and help this patient, even if they're in the ward or after being discharged. They're encouraged they're being taught how to do some active or passive assistive exercise, so that to manage them, to relieve pain. As we know, physiotherapy is one of the pain management in most of the units. Also, assistive devices. If the patient they have some weakness on mobilities, so there are some assistive devices like backrests, wheelchairs, or these walkers, or crutches. So they may be assisted or instructed how to use them, so that they may be comfortable in ambulation. Also, as I said before, better training is very important to avoid the complication, as I said, of pressure ulcers. Most of the patients, they may develop this due to incontinence or urinary retention, which can lead up to feeding injury. So as a nurse in the ward, also we are very keen on that, so that make sure that we are monitoring it collectively and evaluating it and taking action whenever necessary to make sure that these patients are staying comfortable. Also, bowel management, promote and teach on diet, particularly fiber-rich diet. Help this, as we know, this will help in digestion and make sure that the stools come out, it will be soft. Also, adequate hydration and a regular toileting schedule. These are the most key important to educate this patient and relatives, so that they may not end up with a constipation. Because even they get a complication, constipation, they may end up with other complications in new aspects. Also, psychological support is very important, as we know in most societies, particularly in our area here in Africa, these conditions have been termed as the cars sometimes. So we have to educate the family, the loved ones, even the society as well, so that they may know this is the normal. That it's not normal as say, because it's a defect, but it's a condition that can happen to anybody, so that they may know that it is treatable, and once it occurs, so that people they can know where to start, so that to alleviate this problem. So emotional support to the family is very important, as well as to the child or the patient himself. By early diagnosing it, it's very important, and it will help him to cope up with the situation. Also, as we know, this caring these patients or these children, as we know, they're supposed to proceed with their life as normal people, how they do. They have to go to school and do some other activities and play sometimes. Even in a school, so teachers, we have to instruct the teachers, all the people around there, so that they can treat them as the normal kids, and they encourage them to do their activities, involving in some sports lightly, and they study as the normal as the other children. Even for normal children, they be treated, those are things that are happening, not everybody wants, but just happening as abnormalities during growth. So they may take it as a normal thing, so they can cope up with the other kids, and they can play and do their studies as normal. So also here, as we know, this is a multidisciplinary involvement team. We have to involve in the social welfare, so that community workers, they can help to educate the community at large, as they have the chance to reach in many areas, regardless of the nurses they are working in the hospital. But also these social workers, the community leaders, they may be involved in addressing this problem, so that to make sure that to keep awareness to the community, so that they can know that is the normal thing, but it's treatable, and they can be managed, and the people they can go back to their normal life. After being the child maybe as now supposed to be taken for further management, basically surgical treatment. While most of these cases they require not surgical, but if they develop into symptomatic, so they need surgery. Next, the play role in preparing this patient for surgery, and all pre-operative measures that's supposed to be taken thoroughly to prevent complications, and also post-operative care, which include infection prevention, pain control, and rehabilitation support. These are vital to this patient. Also here, post-operative, we have to consider airway assessment, bleeding, to assess the wound, how it is, so that to prevent further damage of the surgical area, and to keep the patient in a comfortable way, so that they may tolerate and develop well, so that the wound can heal well, and the child may be discharged safely for further life activities at home. Also, assistive use of mobility equipment like the best leg walkers and a wheelchair. This is mandatory, because at the beginning, if they have a little bit neurodeficient, as I said before, they need this stuff, so that they may help them to cope up with the condition. the conclusion, as a nurse, we know that they play a great role in the holistic management of the spinal bifida orchid by focusing on early detection, educating the patient and the families, also the pain and the quality and the improvement of the quality of life of these patients. Through interdisciplinary collaboration, patient-centered care, and ongoing support, individual with the spinal bifida orchid can lead to healthy and active life. Thank you. These are references, and thank you for listening.
Thank you, Mr. Shemchua, for such a wonderful presentation. May I call upon commentators to give some comment on the presentation?
Thank you very much.
Matoni, please. You are muted. Yes,
sorry.
please.
Prof. Morota, can you please give some comment
Okay.
regarding the presentation, the nursing aspect?
Thank you very much for the presentation. And yeah, actually, the nurse plays very important role for the family education and the education for the children about the disease, what they suffered. And what is most important is you have to tell them about the possible future tethered cord syndrome even after the initial surgery. This is very important for the family, especially parents, and also it's important for the children to understand they have still have risk of tethered cord syndrome while they are growing. So I always tell them that until they grow, their growth stops, the growth of the height stops, you always have the possible risk of tethered cord syndrome. And even after they've grown up and became adult, sometimes patients refer the tethered cord syndrome. So the importance of tethered cord syndrome must be stressed to the patient and the family. Also, for nursing after surgery, it's very important to take care about the wound. Wound infection is also the high risk, and you have to keep the wound clean because the wound is usually very close to the nail, and there is a high risk of the contamination. Do you have any specific procedure or something to do to prevent such kind of infection?
Yes. In preventing this infection, particularly to the wound, there are dressing always which is being done to the patients, and also dressing material that sterile as always, and that is the sterile procedures we know. Sometimes we use povidone to clean the wound so that to make sure that there is no any bacterial infection that are growing around the wound.
Oh. So the baby is the baby, yeah. Baby is stay in the prone position after surgery, yeah.
Yes.
Do you fix the leg and hand so that they don't turn over or something?
If the baby can control himself by himself, always they stay with their parents on bedside, and they keep watching them. If it's just a grown-up child, ability can understand what they have been instructed. They usually stay with their mothers, but also necessarily they are very close to make sure that they are not turning over the time, so that to prevent this infection.
Okay, thank you.
Thank you, Mr. Shemu. Your lecture was really good. It was a very practical nursing perspective, I must say. It also emphasized the importance on patient education and parental involvement, because we know that the patient care doesn't just stop after surgery, but is continuous until their whole life, and it's continuous, and also it evolves, it changes over time as the child grows. Just I would like to know, from your experience, what are the common concerns or misconceptions that parents have when their children is diagnosed with spina bifida that you have come across?
Okay. There is I don't believe, it's false belief to this most of the patient, of the parents. You know, they must be, they sometimes they think that it's a curse, you know, and this can lead to most of the challenge they face, you know. Sometimes even if the wives or the couple they're married, if the child got this condition, they may end up in divorce. So that is the challenge to the most of our community. And they also termination from work. People that may be terminated from the work. That is the very challenge, the big challenge that are facing these mothers. Also, discrimination and stigmatization. It's being labeled to most of the society around Africa and Tanzania as well. But concerning how to manage that, to make sure that they are cope up with the situation, more education is highly needed. So as now in Tanzania, the government has taken this as a major problem concern, and they have kept it in one of the they kept it in the program of as we know, there is a program of non-communicable diseases. So this one is one, neurotube defect has been kept as one of the major problems. So by next year, maybe they will start working on that in a aggressively, so that to educate the society, so to make sure that they understand the situation, and these things are treatable, because even these kids are being brought into the hospital very late sometimes. Sometimes they are being seen by medical social medias. Then after being introduced to people, then they will be they brought back to hospital for management. So I can say.
Yeah, that's why in every country, education about spina bifida is very important, and also a multidisciplinary approach.
Sister Sylvia, you want to say something?
Yes, thank you. I want to add something on what Mr. Shem have said. In Tanzania, due to these challenges they are facing in the families, we have the spina bifida and hydrocephalus society, where those mothers, after being first they are divorced from their family, they are neglected by the family. The society have the common house where they stay with the children after the discharge from hospital, and the social team from the government have taken the initiative to teach them on how to make some simple things they can earn money to sustain their life. Currently, that is what they are doing.
Oh, that's very good. Does this help with the post-operative follow-up as well?
I don't think.
No, because they stay in the community house, right? Post-operatively after they're being treated. So does this give a better rate of post-operative follow-up? So you get to see them.
Okay, they normally get there after discharge and recovery, but they have very close appointment dates to come to the hospital, and the social welfare, they work so close to the community to see that they are coming for the follow-up in the clinic.
That's actually very good.
Prof. Nancy, you want to say anything? Do you have any comments about the nursing aspect?
Excellent presentation. Without nursing and very compromised work, we can deal with these patients since the diagnosis to the operating table and connection with the rehabilitation. I think the two main issue is, as Professor Morota pointed out, is teaching family how to take care for these patients and how to deal with the society challenging for life for these patients. I don't know in your country, but in our country, usually the family split when the children is very sick since the beginning. Because it's difficult to deal. Usually the mothers stay and the couple don't stay together for life. And even is additional social difficulty to deal with these patients. But very good presentation. I think it's more and more we need to work together to have protocols and try to avoid complication in these postoperative patients since the beginning until the rehabilitation is for life commitment, I think. The people that take care for these patients are special since the beginning. I think we need to take care of each other to stand for them forever. Thank you, Professor Shoma. It's a great advice that we need to take care for them and helping them since we know a little bit more than they know.
Thank you, Professor Nancy. Hopefully one day I'll be a professor.
I listened once. If you are teaching a colleague to do a speech simple like that, you are a professor. You don't need a title to teach somebody. If you are teaching somebody to give something for other, you are the professor. Don't worry. We are not looking for the titles in life. The title will stay here. Our soul will be with all this knowledge that we may share. We are professor in life, not necessary by title. Don't worry.
Thank you, Prof. Nancy. Prof. Gato, you do have something to say?
Yes, maybe we can invite Dr. Fawad from Afghanistan. I think so many cases.
Hello. Salam alaikum. Konnichiwa.
Konnichiwa.
Thank you very much. Arigato. We have also a lot of spina bifida manifesta and occult cases in Afghanistan. But unfortunately, we haven't pediatric neurosurgeon, and this sometimes operated by adult neurosurgeon and sometimes by general pediatric surgeon. And but unfortunately, also we have a neuromonitoring in Afghanistan, and also we have a neuro rehabilitation, and it's unfortunately not good, but we have learned a lot, and we will communicate with our colleagues how to find the train pediatric neurosurgeon, and especially for spina bifida surgery. And thank you very much. We learned a lot. And also, I'd like to say Eid Mubarak for our Muslim brothers and sisters.
Thank you.
Because today is Eid al-Fitr, and it's a religious day for Muslims. Thank you very much.
Thank you.
Thank you, Prof. Fawad. Is there any more comments or any questions?
I would like to have a small question from Professor Morota. After lipoma surgery, you are the more expert on this. Sure you are. We are beginner comparing with your experience. after a lipoma surgery, did you avoid the sitting position for a week, for some days, for some more time, or you doesn't care about sitting position after you do your watertight suture, you close your fascia, and you feel comfortable for don't have CSF fistula like Professor Nadia asked us? Just your opinion.
You know, okay. We do, as I told you, that we do the dural closure, try to do it perfect, and watertight closure of the fascia, and kill the dead space under the skin. And I keep the patient in prone position about 3 to 1 week. That depending on the size of the wound and the defect of the fascia, depending on the situation. And then turn over turn to the supine position and then slowly getting up. And so usually 1 week to 10 days after it takes the patient start to sit up or stand. And even though I do have the CS leakage, very small number, but still I do have. In that case, I did the surgery with the plastic surgeon to bring some muscles from the other part, and then cover the wound and the fascia. Yeah, that I did 2 or 3 cases. I reoperated with plastic surgeon for the prevention of CSF leakage, and yeah, especially in case of the reoperation, second surgery in the elder children, sometimes it needs, yeah, it's not straightforward, as you know. Yeah.
Thank you very much, Professor Morata.
Okay, if there's no further comments or questions, may I call upon Sister Sylvia to round up the second session, please? Sister Sylvia?
Thank you. Yes, thank you, Matoni. Thanks all commentators for additional points on how to go through about that. I'd like to appreciate Mr. Shem for his presentation. Now I have to call up Matoni for the chair and to wind up the session. Thank you.
Okay, thank you very much. We have learned a lot. May I call upon Prof. Kato to give us a little closing remarks, please, Prof. Kato?
Thanks so much. So today we are really lucky because Professor Nelchi and also the Morata is one of the top pediatric neurosurgeon. We can learn so many comments and opinion from them. And also the viewpoint of the doctor and the nurses are totally sometimes different. So I think as a doctor, we need to hear the nurses' care or points. Of course, the nurse should listen to the doctor's lecture and then comment. But I think today's webinar, it's all included. So thank you so much. Your organization, 𝑔𝒔𝒆𝒄𝒊. Thanks so much. See you again.
Thank you, everyone.
Thank you.
For being here, and we learn a lot, and it is a teamwork. We hope to improve and for better patient outcome. Thanks again. Thank you very much. Till we meet again. Bye-bye.
Thank you. Bye-bye.
Arigatou gozaimasu.